what happens anytime that we need to place a stent is that we need to manage that failure that we've had, that we have not been able to remove the clot. So thanks to Paul, it's going to be quite a small talk because the introduction has already been made. So let's try to define the three parts of this presentation. We will start with the problem that we have, then the method, our method, the zero TICI zero study, and our experience using this method. So the problem is that we are not able to open all vessels. It depends, it changes in every center, how many patients. We have not been able to remove the clot with the standard approach. We are getting better, so we have new techniques, the wide stenting, new devices. So this number is being lower each year, but we continue to have a certain number of patients, 20, 10, 15, whatever number that you have, that we are not able to open those vessels. And we know by certain that the probability that we have of getting a good result, it's directly related to the TICI that we obtain at the end of the procedure. So with this graphic, I try to describe what will happen with each TICI. The first part of or the first column is the ranking 0 to 2, then ranking 3, that is something a little bit special because it's not as bad as the 4 or 5, or of course the 6. But I think that what we need to do is to improve the first column. We can pay the price to increase a little bit the ranking 3. Maybe increasing ranking 6, it's not that bad, but we all agree that our biggest problem here is ranking 4 and 5. So if doing anything different than removing the clot increases that number, maybe it's something that we need to be aware. Of course, if the ranking 6 increases crazy, it's also a problem, but that's something that we need to take into account. And we know that the bigger or the better the TICI, the better the ranking 0 to 2 and the lower the mortality. So how many passes should we do? Well, there are lots of papers. You all know about them. I think this graphic, it's really, this figure, it's really interesting, and it describes the probability of a good clinical outcome after each pass. And as you can see, it goes down. In this paper, they discovered that after a 5th pass, the recanalization was futile. It was not useful anymore. I know that we all know patients with 10, 12, 13 passes that have gone well, but this is, of course, from the statistical point of view. So after that 5th pass in this paper, they discovered that there is no, giving more passes, it's not useful anymore, and opening the vessel after that 5th pass was not useful. This is a study that we performed in Madrid in 3 centers. It's called the Matrix study, and we decided to study the probability of getting a recanalization after each pass. So with the first pass, the recanalization was close to 40%, then it grows until 60 with the second pass. So this is the accumulated probability. And as you can see, we can place this on a figure, and it will have this kind of curve where we can see that after the 4th pass, recanalizing the vessel is something anecdotal, and after the 6th pass, it's really strange. How strange it is after the 4th pass? Well, we have lots of patients with a 5th pass. Only 12 of them were recanalized. That's a 16% success. And then after the 6th, it goes down to 4% of success in recanalization. With the 6, with the 7, as you can see, our record in this study was 11. So there was only one patient we were able to open after 11 passes, and we all know that patient. So it's a woman, 29 years old, that you need to open the vessel whatever it takes, because it's really a horrible situation, and we have all faced that kind of patient. So the problem is that we can't open all the vessels, even after several passes, and after 4 passes, it seems that recanalization becomes improbable and futile. So after those 4 passes, opening the vessel, it's really hard, and after opening this vessel, we don't have the same result as with the first pass. So how should we open those vessels? Well, of course, lots of papers, all of them talking about the rescue stenting. Paul has talked about some of these papers, so I will go directly to the options that we have. We have the angioplasty and we have the stent placement. Problem with angioplasty by itself is that we don't know the actual vessel size of the M1 segment because it's closed. Of course, using these centrivers and making the runs in the middle of the procedure, we can imagine that size of the vessel, but we are not sure about that. And we don't know the strength of the clot or the stenosis. So some people, they are afraid to perform this kind of angioplasties in that scenario. And of course, with the stent, the intracranial stents, they have low radial force. We used to do micro exchange after the angioplasty to place a stent, and we have to put the patient under double antiaggregation. So those are the things that we have in mind when we talk about these kind of rescue treatments. In our experience, what we did was compare in all the patients where we failed in this period of time. TICI 01, there were 60 patients in 433 anterior circulation strokes. We placed a stent in 20 of those patients. We did not place a stent in 40. Of course, this is a retrospective study, so we have all the bias that you can imagine. First of all, we were placing stents in the patients that we believe they were going to be better. What does that mean? Younger patients, higher aspects, so it's a quite selected sample, and you need to know that. Why? Because these were the results. After placing the stent, we got 45% of good clinical outcome, while if we don't place the stent, it was as low as 2.5%. I know this is really low, but it's because what I have already told you. If the patient was really bad, if the aspect score was low, old patients, we did not place a stent in this study. So maybe that's why we have that low number. But if you read the literature, the numbers are pretty much the same if you are doing a retrospective analysis. Okay, 44% in this paper by Paul, another one with 40%. So we know it should be around those numbers. So when to place a stent? Well, this is the data that we have in our hospital with our first 674 patients, number of passes, good clinical outcome. And it's pretty much the same as what we have already talked about in the first figure that I showed you. So as you can see, from the 60% good clinical outcome on the first pass till the 0% on the 8th pass. So, okay, so this is when we were able to obtain recanalization. So we know that placing stent should be in those 3 to 5 passes, because that's the result that we obtain. So placing stent, we are talking about 40% of good clinical outcome. So it seems logical to be placing a stent in those positions and not wait for further passes, because that probability will become lower and lower with each pass. And of course, we know that after that third pass, the hemorrhagic complications increase. So we are facing a different scenario than a LVO obstruction that we've been called. This is quite different. We are facing a scenario where we are treating a patient with a resistant clot that we have not been able to remove in 3 passes. We have higher risk of hemorrhage, and we have lower percentage of successful recanalization and good clinical outcome. So this is quite different than a normal stroke patient. Our method, what do we do and why do we do each thing? It is called the zero TICI zero study. It's to avoid what Paul says, that we don't want TICI zeros in our life, because we know they are really bad for the patient and for our morale. So we perform 4 passes, and that's a maximum. It's not a minimum. Okay, so we will place the stent always after the 4th pass, and we are talking about the 4th pass on the same location. If you are treating a TICA and then it moves to the M1, it changes. So it's not the same. Okay, so 4 passes on that specific location. We perform a CT in the angio room to rule out any kind of hemorrhagic complications. thanks to Philips, Siemens, and all the machines, these CTs, they are becoming better. So these images, it will be better for us to rule out these hemorrhagic complications, but we look for big hemorrhagic complications, not small subarachnoid hemorrhage, okay? Then we place the patient under, in our case, tirofiban, the agrastat, and we perform an angioplasty with neurospeed, and we place a credo using these two good friends that we have. So we are able to perform the angioplasty and place the credo really fast, so we can do this treatment in a really straightforward manner. So this is the combination that we use. And how we work with medication, well, this is how we do it. I know that there are different regimes, but this is what we do. So we take the decision to place a stent, and we put the patient under tirofiban for 12 to 24 hours. Then we perform a CT and an angio-CT. CT to rule out any kind of hemorrhagic complications, angio-CT to prove that the stent is patent and it's open. Because if it's closed and we have a big infarct, we don't place the patient under double antiaggregation. So if there is no hemorrhagic complications and the stent is open, we change tirofiban to aspirin and Plavix, and we do it all the same, all together, because, well, the tirofiban has 2 hours of half-life, and that's the time aspirin and clopidogrel will take to be useful in the blood. So we keep the patient under double antiaggregation for 3 months, and then with simple antiaggregations for the rest of his life. There is something important, because on the TPA technical documentation, they will say that you cannot place the patient under double antiaggregation in the first 24 hours. Okay? But that's for secondary prevention. That's to treat the future risk of stroke in a patient. In this case, what we defend is that we are placing a stent and we are putting the antiaggregation to keep the stent open. Okay, so that's the technical part or the legal part that we have. Is it safe? That's the other question that we have. This is, I think, is an early big study where they show that putting the patient under tirofiban, it's safe protocol for patients with a failed mechanical thrombectomy. So we know that it works and it's safe. Let's talk about our experience. And I'm going to be really fast in this part, but these are the patients that we treat. So as you can see, since the beginning of Zero TICI Zero, we stop selecting patients. We even treat patients with ranking 3, okay? So I think that's important for you to know. And of course, they are not perfect patients anymore. This is the 65% of women, NIH of 17, and the median aspects was 9. So we put the patient under IVTPA 31% of the patients. The time from onset to the start of the procedure was 3 hours, and then the procedure time was 1.5 hours. And it's pretty much, I think, average number, so it's 4 passes, so we are talking about longer procedures. The median number of passes that we perform is 3, because we are becoming more aggressive. If we believe that it's a stenotic problem or something behind that clot, then we will go directly to stent placement. Which vessels do we treat? Well, 18 of them were M1 segment and only 1 TICA. M2, we've been able to place stent in 5 patients and 2 posterior circulation patients. What do we do? 60% of the time we perform an angioplasty before placing the stent. 88% of the time we place a stent, so there are 12% of patients that we did only with angioplasty. 31% of these patients were under general anesthesia. And I think this is a number that needs to be explained, because people try to do these procedures under general anesthesia, and I understand that, but in a specific hospital, it's quite complicated not to get a general anesthesia, that's really easy, but to ask the anesthesiologist or the intensive care unit to wake up the patient early after the procedure. So if we put the patient under general anesthesia, then it will be intubated for 12 or 24 hours. And we are really interested in know if it has worked or not, if there are some changes or not, and we miss that part. So that's why we try to do it without this general anesthesia. Angioplasty, well, this is the things that we have used. Most of the time this Aclino, because it's what we used to have in the first years until we get to Credo. Right now we're using Credo 100% of the times. This recanalization after stent placement, it gets to 77% of TICI 2v3, so it's quite nice if you remember that we were treating patients with a successful recanalization of 16%, so this is quite an increase in the numbers. What complications do we have? Well, we have 7 intracranial hemorrhage. 5 of them were subarachnoid hemorrhage, this kind of a little bit more than standard small intracranial subarachnoid hemorrhage, and 2 parenchymal hematoma. One of them was because of a hemorrhagic transformation, and the other one was because the vessel was ruptured beyond the obstruction points. So when we placed the stent and we put the tirofiban, as you can imagine, it was a terrible result. And that's the patient where we change this procedure and we start doing the CT to everyone. Results at 24 hours, 81% of the stents open, 15 of them closed, and we have only this complication. And these were the ranking scores at discharge below and at 90 days. We are talking about a 35-37% ranking 0 to 2 at 90 days. So it's a little bit lower than what we used to have, but don't forget, these are not selected patients. These are all the patients with a 0 TICI 0 that we know they can have some kind of improvement. So we are not putting low aspects, we're, things that we believe it's going to work. And I want to only talk about this graphic, the one that's on the bottom right of your screen. Those are the results at 24 hours divided by each technique. So green is vessel open, red is vessel closed. With angioplasty, the problem is that the number is not that big. I think it's 5 or 6 patients, but half of them, the vessel was closed at 24 hours. So we stopped doing this kind of procedure and we start to place much more stents that we used to do. I know these are not numbers to take into conclusions, but if you see those numbers on the first 4 or 5 patients, then you will be afraid of putting the patient under angioplasty only. And I must explain that those patients, they were all of them under tirofiban. So anti-aggregation regime was pretty much the same, even if we place the stent or not. Okay, so those were the numbers that we obtained. So at discharge, again, the ranking, as you can see, but don't forget, we are not treating average LVO patients, we are treating resistant clots. So the prognosis, the everything of that patient are much different than normal patients. So when do we place a stent? Well, we do that after the 4 pass, and it's because we want to get those results. But if we get those results after the 4 pass, the next thing that I am thinking is, why not after the 3rd? Or why not after the 2nd pass? We all have lots of patients in our bags, and we know when we are not going to be able to remove the clot. We know that if we have done 2 passes with the correct technique and that everything has worked perfectly, we know that. So if after 2 perfect passes we are not able to remove the clot, maybe placing the stent will give us and our patients better results. That's the question that we need to answer in the nearby future. This is a paper published, I think, a couple of weeks ago for German group and the German registry, where they show that after 3 passes in posterior circulation, the mortality increases and the ranking decreases too much. So it seems that in posterior circulation, we are getting much more aggressive than in anterior, and we can place the stent after the 3rd pass. So conclusions, we cannot remove all clots. Stent placement can be an option, and investigations are ongoing to prove its efficacy. Of course, it will be great to have a prospective trial, because I am pretty sure that the NNT will be amazing. Thank you very much.
Thank you very much. Great talk. Are there any questions from the audience? Hannes. Thank you very much for this fantastic talk. I really like your pragmatic way of saying after 4 passes we go for stenting, but I would make some exemptions. So if you still retrieve lots of clots, and with the 4th pass you still retrieve clot, wouldn't you go for a 5th pass and say and see whether you still retrieve clot and then stent once you do not succeed anymore?
I think so. The problem is that when we were designing the study, we were really afraid about hemorrhagic complications. That was our main concern because neurologists were really afraid of this specific part. So when we designed this study, we look for lower hemorrhagic complications. That's why we decide to put a limit of passes. But that means that you cannot go inside the study. That does not mean that that's the thing to do in every patient. You know, so to get inside the 0 TICI 0, the limit is 4 passes, but in your daily practice, of course, if we are retrieving clot and we think that we can continue to give more passes, then we will do that. I will tell you, I have not done that in the last 2 years. Because not because that I am a crazy 0 TICI 0 guy, it's because we have not get that kind of patients. Right now we start with combined approach. If it's not working, then we will go to maybe a wide stenting. Then, so as our aggressiveness it's increasing, after the 4 pass, normally we are not getting any clot material.
Okay, and if you have no flow and you have, as the case that Paul mentioned, don't stent if there has never been any flow, you don't go for stenting?
Yeah.
Okay.
So if the runs that we do with the bypass effect, if everything's closed, then.
Question from Paul, I think.
So I think you are also enthusiastic about stenting earlier, but I fear a little bit when you look at the era before thrombectomy devices, before the retrievers, there were hundreds of papers proposing putting a stent in a stroke and it will be fine, and the results were not good. So I think I'm not sure if it's really the best way to think about the statistics of passes and the likelihood to reopen. I think when there's a lot of clot, a stent is a bad idea. And we know this from the era before, so I'm pretty old now, and I know all this work putting stents just into a occluded vessel, no? Into a clot. And I think when you have the impression there's no much clot, and when you do a first pass and there's nothing, and you think this is a stenosis, put the stent after the first pass. Why not? And if there's still something coming out, like Hannes has always a lot of clot in Solingen, and when you can take out more clot, or there's one M2 occlusion still with a large clot, take it out. And I would not become too enthusiastic with stenting because we had this 15, 16 years ago.
The thing is that, as you can see, data speaks by itself because we have placed only one stent in a terminal carotid, and that's the one where you usually have more clot. On an M1 segment, the amount of clot that you are able to extract is not that big. So that's maybe because we are trying to remove as much clot as we can. Yeah, of course. And if everything is thrombosed, it's not going to work. Because you have to place